Good evening to everyone and welcome to today's session. Today we shall review 4 very important topics in microbiology: Staphylococci, cholera, chlamydia and diphtheria. And also we'll have a quiz. We welcome our online students Dr. Gaikwad, Brahmaramba, Chandan, Lakshmi, Kavita, and the students of Tirupati, Guntur and Vizag. So, yes, can you please punch whether the voice is clear and loud without any echo? The online students, please punch. Yeah. Staphylococci, they're the darkly gram-positive organisms is what you need to remember. They tend to occur in bunches like grapes. One of the favorite MCQ of the examiner, because of that type of division, due to that, they clustered like a bunch of grapes is what we need to remember. For the Staphylococci, you require enriched medium, culture medium. Why, sir? Because for the Staphylococci to grow, it requires a lot of amino acids and growth factors. Unless you add it into the culture medium, they can't be able to grow. That's the reason only enriched medium is the one which is required. What kind of organisms are the Staphylococci is my question to all of you. They are facultatively anaerobic organisms. They produce catalase. And what is the importance of this catalase? It is this catalase which differentiates the Staphylococci from that of the Streptococci. Streptococci are catalase-negative organisms, whereas Staphylococci only produce the catalase. Don't confuse with coagulase. Staphylococci may or may not produce coagulase, but all Staphylococci need to produce catalase. Streptococci do not produce catalase. Of all the species, it is the Staphylococcus Aureus. Please let me know if you have any echo in the voice. Don't hesitate to tell. I'm little conscious that echo is there. I hope it is not there. Good. The most virulent is the Staphylococcus aureus, and almost all the isolates will be secreting the coagulase. And how do you recognize that it is producing coagulase, doctor? Typically, if coagulase is being produced, then the plasma gets clotted. This is not producing coagulase. That's the reason there is no clotting of the plasma. So the presence of the coagulase causes the citrated plasma to clot, which is the way to recognize the presence of the Staphylococcus is what you need to basically remember. If you grow it on a nutrient agar in an enriched medium, how do the colonies look like? They are large, circular, convex, smooth, shiny, opaque and easily emulsifiable. And why do you call aureus? Because they are gold colored. Colonies is a very, very characteristic feature. So typically that gold colored pigment makes Staphylococcus aureus to become a aureus. Then on the McConkey's agar, they will be typically small and pink, and on blood agar there will be beta hemolytic colonies, but these things nobody will ask. On McConkey and beta hemolysis, alpha hemolysis is all the story to remember about. Streptococci, optocin sensitivity, basitrin sensitivity, Streptococci, novobiosine sensitivity, Staphylococci. So you need to be very clear. Otherwise in textbook, all culture medium, what happens, it will be given like a big list. No point in remembering all that stuff. So catalase test if you do, typically catalase will be positive is what need to be basically remembered. Then coagulase test, two types you can do. One is called tube coagulase test, where you observe the plasma getting clotted, and other is called the slide coagulase test. Finally, the principle is the same. Now, doctor, why do we need to wash the hands when we are touching one patient after the other in the grand rounds in intensive care unit? Are we bothered about streptococci or staphylococci? Staphylococci we are bothered. Why? Because staphylococci are hard, resistant organisms. If you heat them, you dry them, still they live. That's the reason on the inanimate objects like fomites, staphylococci, not streptococci, staphylococci will be typically persisting. And if you touch one patient's bed, one patient's linen, and then go to the next patient in the rounds and examine the next patient with the same hands, then staphylococcal infection can spread. One of the very common sources is through the hospital personnel not following religiously the habit of hand washing when they're examining the patients is what you need to remember. Now, if you look at the staphylococci doc, you need to remember that unless some compromising factor is there in the host defenses, staphylococci doesn't infect. Either there should be some break in the skin, some insertion of a foreign body like a central venous catheter or a surgical infection should be there, or something like an obstructed hair follicle can get infected and lead to folliculitis, or the patient may be immunocompromised. Unless some breach in the immune system of the host is not there, staphylococcal infections do not occur, is what you have to basically remember. So what does this remind you, doctor? It reminds you folliculitis. Folliculitis is what need to be remembered. Now we are going to talk about what are the various toxins produced by the Staphylococcus. That is the whole story of the Staphylococcus in microbiology is all about toxins. There is a beautiful capsule, a peptidoglycan layer, and a polysaccharide A, it being a gram-positive organism. Teichoic acid is there. There is a protein A, which is very important to prevent for the staphylococci to defend itself from the attack of the phagocytes. And there is one clumping factor and one cytoplasmic membrane. So these are all the things in the structure. Now, doctor, what are the various virulence factors in the case of the staphylococcus? Capsule. Basically, the capsule is made up of polysaccharide slimy layer. That's the reason if you look at most of the clinical isolates, they all produce type 5 or type 8 polysaccharide microcapsule, and because of this capsule there is a resistance to phagocytosis. So that's the reason it is one of the important virulence factor, capsule. Is the capsule very thick like your streptococci? No sir. So it is thin, it makes staphylococcus resistant to the attack of the phagocytes is what you have to basically remember. So always there is a dynamic fight, war between staphylococcus and our defense system, complement system, macrophages, etc., etc. So if you look at the structure, this is very, very important about staphylococcus. Protein A, coagulase, collagen binding protein, fibronectin binding protein, clumping factor. These are all the important parts of the staphylococcus. Now what is the importance of each of them? Protein A. Protein A is one of the major components which will go and bind with the Fc region of the immunoglobulin G of the human immunoglobulins. And After inserting, it will create a antioxidant effect. It will tell immunoglobulin G, see, I am a non-resident Indian in America. I have a visa. I am supposed to live here, it will tell. Immunoglobulin is that visa officer. He will think, oh, this fellow is a normal guy and he won't injure it. Antigenicity. For the antibody to get angry will be brought down. Antioxidant effect is there for the protein A is what you need to remember. Then there is a fibronectin binding protein which will promote the binding of the staphylococci to the tissue and the mucosal cells. There is a clumping factor which will make organisms to clump in the presence of plasma, and there are various cytolytic exotoxins which are being produced. This is very important. In microbiology, one of the common questions asked is, what is the mechanism by which organism is dangerous? Is it directly due to invasion or is it due to toxin production? So that is the reason we need to be very clear. Is it a toxin producing or not? If so, what is the most important toxin? Is one of the favorite questions of examiner. Alpha, beta, gamma, delta, so many toxins are there. All of them are fundamentally hemolysins. They typically lead to breakage of the human red blood cells. Alpha toxin. Where is the intelligence to produce this alpha toxin? Basically, there is a chromosomally encoded gene which is being identified, which is the source for the production of this hemolysin called alpha toxin by the Staphylococcus. And very important type of toxin which can be very important type of toxin which is one of the favorite question of the examiner, which you need to be very clear. Pantene valentine leucocidin. You need to remember February 14. So, Pantene valentine leucocidin. 2 points you know about this toxin. Only 2 points. It forms the pores and breaks the PMNs, polymorphonuclear leukocytes. Presence of this valentine leucocidin will make the staphylococcus become more virulent, and mainly MRSAs, you know, no? Methicillin resistant Staphylococcus aureus strains. Initially, Staphylococcus was listening to penicillin. After that, it became resistant. We started using methicillin. It became resistant. We started to use vancomycin. It became resistant to vancomycin, and we already discussed in pharmacology. What Pristin? Huh? Anyway, we will discuss that. So, Dalphi, something to do with Dalphi. We'll come back to that in the last part of the story. So, this methicillin resistant Staphylococcus aureus strains are there, no? They are very romantic. They produce Pantene valentine leucocidin toxin is what you have to basically remember. So, doctor, this is the Staphylococcus aureus. It is producing PVL, valentine leucocidin toxin. It will go and damage the neutrophils and break down the neutrophils. It's like a policeman has gone to arrest and he has been killed and beaten by the thief. So that kind of a story is valentine leucocidin toxin. Now doctor, superantigen exotoxins is a very special type of exotoxin. Quinpristin, says Akshara and Anu. Quinpristin, if there is any resistance to vanco. Superantigen now we are talking about. What is this superantigen? Basically, if there is an antigen, antibody is produced. T cell become activated. This superantigen basically has a strong affinity for the T cell receptor and MHC class 2 antigen complex. See, you have T cell has a T cell receptor. Then you have an antigen presenting cell and it has got a MHC2. And both of them carefully hold the antigen and then antigen will be killed. So there is an antigen binding groove here. What will this superantigen will be doing produced by the Staphylococcus? It has a strong affinity for binding with this T cell receptor MHC2 complex which is holding the antigen. And by doing that, the T lymphocyte stimulation will occur. No? Basically, antigen presenting cell, when it presents antigen to the T cell first time when it recognizes, even when I am on duty, this fellow has stolen the entire house, it will become very angry. Lathi charge, it will say. But in this case, it will say, fire the gas shells. Lathi charge will not do. This is a very serious mistake, police officer. You need to be very, very furious. Superantigen will be stimulating the T cell. T cell become exuberant everywhere. Anybody who comes its way, it will start killing. And person dies. That is the story of superantigen exotoxin. By basically attaching to this MHC2 TCR complex, it will basically lead to a enhanced T lymphocyte response. If the superantigen of the Staphylococcus comes and binds, 1/5 of T lymphocytes will catch the guns and get into the battle. If it is only antigen, without superantigen of the Staphylococcus binding, then what will happen? 0.01% of T lymphocytes only get recruited. Hardly 2 or 3 beat constables will be put on duty regularly. If superantigen is there, entire reserve police force battalion is being called. And there will be gas bombs, everything being shelled out. So that will happen. Why superantigen will do like that? What gives that speciality for superantigen? Basically, there is a conserved area in the T cell receptor. Then regular antigen does not know to go and touch it and switch it. Superantigen only knows where is that located, and it will go and switch it and lead to exuberant T lymphocyte response. So, because of this T cell activation, there is a toxic shock syndrome, exuberant release of the interleukin 2, interferon gamma, TNF alpha, etc., is what need to be remembered. So, a conventional antigen reactive clone will produce the B cell, and that typically lead to development of B cell clones like that. Whereas when a superantigen comes and binds, there is a huge release of a lot of inflammatory mediators, apoptosis, everything will happen very rapidly. Now, what are the various enterotoxins of the Staphylococcus? A, B, C, D, E and G. They are all the various enterotoxins. They contaminate the food that we eat and responsible for the Staphylococcus aureus, leading to the development of food poisoning. What is a very important thing in the history of the patient who is having staphylococcal food poisoning, doctor? Severe vomiting. Food poisoning with severe vomiting. Because this toxin knows to stimulate the vomiting center in the medulla, is what we have to basically understand. Then one more important speciality of this toxin is, generally we will be of a innocent thought. What is that? We go to the medical college canteen and say, एक जल्दी फटाफट समोसा हीट करके दे दो. Give me one nice sandwich heated in the furnace. We think heating will be able to do some help. No sir. Heating will kill the organism but cannot denature the toxin. Poison is not detoxified by heating. Snake died. You got no? Venom is not detoxified. Ultimately, whatever that sandwich you are eating, you are taking the poison inside, right? So, if it is hot, it won't infect is wrong. Is not true when it comes to Staphylococcus. It will have a preformed toxin. Ready-made toxin is available. You eat, I will cause you food poisoning, it will say. So, enterotoxins are the superantigens, and they are more heat stable than Staph aureus. That's the reason if you are suspecting food poisoning, will you put it under microscope and look for some grape-like clusters? No, sir. Already grapes, clusters, everything is burnt away. What is left is toxin. Detection of the toxin is a way to confirm a food poisoning, not the detection of the Staphylococcus aureus is what you have to fundamentally appreciate. Now, what are the various manifestations, other important toxins? Toxic shock syndrome, toxin 1. Don't worry, there is no 2, 3 or 4 TSST. I was also thinking, suddenly, recently any new things have come, where is this one came from? Only one is there. So, one and only one. Then there is a exfoliative toxin. Here comes the most important confusion while you are answering the questions. In exam, they ask a question, scalded skin syndrome caused by the Staphylococcus is because of what? One exfoliative toxin will be given, other is toxic shock syndrome, toxin 1 is given. It is not toxic shock syndrome, toxin 1. It is the exfoliative toxin which is responsible for the development of for the development of scalded skin syndrome in children is what you need to remember. Why, if scalded skin exfoliative toxin is produced, the skin of the baby peels off in scalded skin syndrome is an important question of the examiner. Basically, it will break down a protein called desmoglin, which is a very important component of the desmosomes, which will keep the cells adherent to one another. And the breakdown of that by this exfoliative toxin is responsible for the easy peeling off of the skin when there is a scalded scale syndrome is what need to be remembered. Now, doctor, let's look into the various infections which are caused by Staphylococcus. Basically, there are some localized skin infections, some deep infections, and some systemic infections. The most common Staph aureus infections are all small superficial abscesses involving the hair follicles. What do you call them? Folliculitis. Then even sweat glands, sebaceous glands, any of them can get infected. And I still remember when we were in final year MBBS, one of our classmates had a inguinal hair follicle staphylococcal infection, which has swollen. Same time we were having a inguinal hernia lecture. I mean, case presentations, everything is going very strongly. So he went into depression. Inguinal hernia hai mujhe, inguinal hernia is there. We were all telling, don't worry, it won't be that painful. So almost another half of the batchmates examined him. Everybody was thinking that what is there in the inguinal area is only a simple folliculitis. I mean, but still he went almost into a morbid proposition. And on the top of it, he had a misapprehension. Because of any sexually hyperactivity, there is a development of an inguinal hernia. At the end of all counseling, we have given him cloxacillin and everything resolved. So we called the cloxacillin resolved inguinal hernia, a special paper. So as medical students, we always worry about whenever we study malignancies, we start thinking they all exist in us. So doctor, I mean, suddenly I remember our, but that guy now is one of the very famous psychiatrists. He ultimately became a psychiatrist practicing in Hyderabad only. So with anonymity maintained. So common stye, external hordeolum is a stye is what need to be basically remembered. That's right. Prashant is asking, what is carbuncle? What is furuncle? We are coming to that point shortly. This is also staphylococcal. This is another favorite MCQ in the exam. Stye is because of strepto, staphylococcal, pseudo, etc., etc. Then furuncles are subcutaneous abscesses altogether, and they are often around a foreign body like a splinter. There is a development of furuncle. So the stye, the boils and carbuncles, the furuncles, pneumonia, impetigo, endocarditis, UTI, scalded skin syndrome, osteomyelitis. These are all the things we need to remember when we talk Staphylococcus. Now, carbuncle, what does it mean? We said furuncle earlier, right? You have seen furuncle. Furuncle is subcutaneous in its plane as an abscess, whereas carbuncle is more larger, more deeper, and multiloculated skin infection. And carbuncle, unless you do debridement, first anyway drain it, is the basic surgical principle. It can lead to bacteremia, is what need to be remembered. So typically, if you look at a boil, otherwise called furuncle, the plane at which it is existent, it is not multiloculated. It is basically subcutaneous. Whereas multiloculated, more deeper will be what you call as carbuncle, is what need to be remembered. So impetigo, paronychia, cellulitis, any of them can be the features of the staphylococcal infection. So what is impetigo? Impetigo is much more commonly caused by Streptococcus pyogenes, but it can also be due to the staph, and it is usually a localized, superficial, spreading, crusty skin lesion seen in the case of the children. More commonly strepto, it can also be staphylo, is what need to be remembered. So these are the typical lesions of the impetigo. If you are seriously going to a pediatric posting in a government hospital, without seeing a case of impetigo, very common, quite common. Now, deep localized lesions, what are they? Basically, osteomyelitis, acute and chronic, can be due to Staphylococcus aureus. In fact, it is the most common cause for both acute and also chronic infection of the bone marrow. And it is also the most common acute infection, septic arthritis, in the case of the pediatric population, is once more Staphylococcus aureus. It can lead to endocarditis, septicemia, pneumonia, nosocomial infections, etc. Now, Staphylococcus is known to lead to toxinosis. 1 2 comments about each of these toxinosis. We have a toxic shock syndrome. In the modern era, it is less likely to find toxic shock syndrome. Once upon a time, when hyperabsorbent tampons by the women who are too hygienically obsessed, so they were having the vaginal colonization of the toxic shock syndrome toxin positive strains of the Staph aureus, leading to the development of toxic shock syndrome. Staphylococcus can lead to gastroenteritis. Commonly, it is the food handler, chef, master chef is responsible. And what kind of foods is a favorite MCQ of the examiner? Typically in the history, when you see salads are eaten, cream pastry was eaten by all the school children, developed nausea, vomiting, diarrhea. Only think of Staphylococcus. The foods which are rich in protein like egg salad and cream pastry. Similarly, the foods which are salty like the ham. Why? Because the Staph aureus is salt tolerant. Any amount of salt you put on that, still it can survive. improperly refrigerated food. These are the buzzwords in the case history. Think of only Staphylococcus as your answer. And these toxins are very heat resistant toxins. So if you happen to heat and subsequent reheating, if you do also, they can still survive. And nausea, vomiting, diarrhea, they're all acute, explosive onset will be there with Staphylococcus. Now comes a very important MCQ. Incubation period is less than 6 hours. Only 2 organisms in the entire microbial world have such a short incubation period. One is Staphylococcus aureus, other is Bacillus cereus. Only 2 organisms have a short incubation period less than 6 hours. And it is not Staphylococcus goes and attacks intestinal cells, leading to the development of staphylococcal diarrhea. It is the toxin by its local action will lead to the development of the triggering of the diarrhea is what need to be remembered. Now, why is the incubation period is so short, doctor? Is there any special reason? Yes. The toxin of the Staphylococcus is already preformed even before the food is heated. And even if you heat the food or when you heated the food, the toxin did not denature and hence it is still toxic. That's the reason there is no time taken. Staphylococcus need not become pregnant, it need not carry gestation and then deliver the toxin, not required. Already she gets married into your food with a baby, like a not Indian marriages, foreign marriages. Already husband will have 2 children, wife will have another 3 children, they will adopt another 4 children. All the 10 children will bless the marriage of the dad and mama. So it is that kind of arrangement. Staphylococcal toxin is already preformed. Now, doctor, scalded skin syndrome is a very important entity. It is the exfoliative toxin which will lead to desmoglein breakage, leading to the injury of the stratum granulosum, one of the favorite MCQs of the examiner, lead to development of the epithelial desquamation, leading to the development of the scalded skin syndrome. So, Ritter's disease, pemphigus neonatarum, toxic epidermal necrolysis, bullous empirico. So, these are all the words that should make you to think about Staphylococcus. Now, how will you identify Staphylococcus, doctor? It is strongly gram-positive, grape-like clusters, and coagulase test will be able to differentiate Staphylococcus aureus, which has coagulase, from the coagulase-negative staphylococci. And the aureus colonies are all fundamentally golden yellow in color whenever you grow them. Whereas coagulase-negative staphylococci are there, no? Their colonies are grey, non-hemolytic in nature, is what you have to fundamentally remember. Then one very important feature, doctor, tomorrow in the MCQ, if you get a word, mannitol positive, gram positive, cocci, you should only think of staphylococci. Staphylococcus aureus need to be distinguished from the coagulase-negative staphylococci because only Staphylococcus aureus, which is coagulase positive, is only mannitol positive, not the coagulase-negative staphylococci is what need to be remembered. Now, how about immunity? There is no long-lasting immunity. Last month we had a food poisoning, doesn't stop us to go to hotels, doesn't stop us from eating anywhere. So that's the reason have menu in the streets and food in the home is the rule, whether it comes to any expedition of life. So if you have food everywhere, no time the GIT becomes a toilet. So there is no lifelong immunity to that. Now, Alexander Fleming is an unhappy man. His soul was unhappy to discover that Staphylococcus no more is listening to what he discovered, penicillin. Once upon a time, it is very penicillin sensitive, but later it became resistant because of the penicillinase encoding plasmids and transposons. So, we have discovered for penicillin resistant strains methicillin. Then methicillin resistance developed. There are two kinds of methicillin resistant strains. One are called hospital acquired methicillin resistant Staph aureus, other are called as community acquired methicillin resistant strains. Why do we know? Why do we need to know? Is there a difference between, finally it is methicillin resistant only, whether it is hospital acquired or community acquired, what is the difference? There are a couple of differences which are the favorite issues for the very shrewd examiner. If he is very particular, he can ask you as a question in the exam. So let us be very sure. Antibiotic resistance to the methicillin, if you say, it is mainly caused by the acquisition of a gene called as gene for a special penicillin binding protein PBB2A. Basically, what is the way beta-lactam antibiotics show their effect on the multiplying organism? They will go and bind with the penicillin binding protein and they alter the activity of the transpeptidase and interfere with the peptidoglycan production so that the cell wall synthesis cannot happen. So these organisms basically develop a special type of penicillin binding protein PBB2A which doesn't bind with the beta-lactam antibiotics. That is how the resistance will basically develop. Then if you look at the community acquired methicillin resistant Staph aureus, what is its special way of presentation? Soft tissue infections like abscesses and cellulitis. They are the most common clinical presenting feature of community acquired MRSA is what you need to basically appreciate. And the community acquired MRSA, it has a very special pattern of the DNA fragments if you do a enzymatic cleavage of those DNA fragments. And community acquired MRSA, if you take doctor, it is still sensitive to the action of ciprofloxacin and clindamycin, whereas hospital acquired MRSA are there, no? They are resistant to even ciprofloxacin and clindamycin also, the alternative drugs. So who is more bad? Hospital acquired MRSA are more dangerous than community acquired because community acquired MRSA are still sensitive to cipro and clindamycin is the point of interest. So after methicillin resistance developed, we discovered vancomycin. So these are the vancomycin sensitive Staph aureus and these are called VISA. Vancomycin insensitive Staphylococcus aureus are the two different groups. But that is good news about community acquired MRSA. Alternative drugs can still help the people. But if you look at the amount of virulence, community acquired MRSA are more virulent than the more common types of hospital acquired MRSA is the second difference. They are more virulent but more sensitive to the alternative drugs. Who? Community acquired MRSA. So whenever there is a life-threatening MRSA, vanco is the agent of choice. Then later on vancomycin resistant strains are developed. And what is the drugs that we use, doctor? As Prashant has rightly reminded us, quinipristin, dalfopristin, linezolid and daptomycin are the ones which we use for the management of vancomycin resistant strains is what need to be remembered. Now doctor, Coagulase-negative Staphylococci. 1-2 comments about them. Immediately when you get a phone call from the microbiology lab that the Coagulase-negative Staph Aureus have grown means what comes to our mind? Generally it is synonymous with Staphylococcus epidermidis. Am I right? In fact, it is the most abundant and most important Coagulase-negative Staphylococcus. But Staphylococcus Saprophyticus, it is typically associated with the use of the implanted prosthetic devices and catheters. Which one? Saprophyticus. One of the favorite questions of the examiner. You thought coagulase, if it is not there, it is very benign? Nobody is benign, doctor. Everybody is clever enough. Says the Staphylococcus Saprophyticus. I may be looking innocent, I may be more vulnerable, but don't take it, what is that famous buzz line? Don't, Dirty Dancing movie. Don't push me to the end, says Saprophyticus. I am capable of infecting the prosthetic devices. Tomorrow you may be an orthopedic surgeon. Tomorrow you may be a very top heart surgeon. All your ambitions to treat with processes may be baffled by the Staphylococcus Saprophyticus, which is otherwise innocent. Similarly, when you pass indwelling catheters, Staphylococcus Saprophyticus is very, very dangerous. Now, doctor, Staphylococcus epidermidis, 1-2 comments about it. Typically, whenever a blood culture, it is evening 6 o'clock, you are a medicine resident, you are just leaving the hospital, but you told the nurse, hey, please don't leave. I being resident, I have a chance to leave, you can't leave. Take that blood sample for the culture and send it to lab and then you go home. If not, I'll see you tomorrow. If you say, what will she do? Oh, this fellow is a useless fellow. So, he doesn't work, but does a armchair management and instructs everybody, she will think. So, you left. Then she will take a nice syringe without any cleaning or sterilization. She will draw it and throw it. She will call a student nurse and give her. You throw it there and go to hostel and I am going home, she will say. So that got contaminated by the skin. And next day, big report came. What is that report? Organisms are growing. We are going to tell you what are they. And your enthusiasm is growing as a resident. Wow, what a great discovery I did. Even at the end of the day schedule, I am able to make a huge diagnosis of endocarditis, you will be thinking. Ultimately, it comes out to be contaminant of the blood sample. So that's the reason while collecting, doctor, no hurry. While doing procedures, don't keep running. Do it with all that stability, nobility, ability, agility of the mind. So that is very essential. So, Staphylococcus epidermidis can be a contaminant. Now, though the Staphylococcus epidermidis has a low virulence, like Saprophyticus, it is a cause of infection for implants like heart valves and catheters, both Saprophyticus and epidermidis. And if you look at the drug resistance of the Staphylococcus epidermidis is more than the drug resistance which can happen to the Staphylococcus aureus, is what you need to remember. But if you look at this Coagulase-negative Staphylococci, luckily there are methicillin resistant strains, penicillin resistant strains, but there are no vancomycin resistant strains as yet prevalent. Now, doctor, why placing a indwelling catheter predisposes to the development of the Staphylococcus infection is an important question you need to answer. These Coagulase-negative Staphylococci, they produce an extracellular polysaccharide material called as polysaccharide intercellular adhesin, also called slime. Because of this slime, It will enable the organism to adhere to the bioprosthetic material of that indwelling catheters or a prosthetic material, and that enables it to, so it is not that virulent, that much capable of breaking the barriers and entering, or it does not produce a very big toxins like its coagulase positive counterpart. Still, it leads to prosthetic infections is what need to be remembered. So, intercellular adhesin, slime are the buzzwords you are going to remember when it comes to Staphylococcus epidermidis is what need to be remembered. Then, Staphylococcus saprophyticus. Typically, it is a frequent cause of development of cystitis in the case of the women. Severe pain, abdominal pain, your patient walked into your OPD. Staphylococcus saprophyticus, very common cause. That's the reason. What is the other adage? You remember? Urinary coagulase-negative Staphylococcus, if the report says has grown, it is synonymous with Staphylococcus saprophyticus. In fact, it is a part of the normal vaginal flora, and luckily it is sensitive to penicillin, Staphylococcus saprophyticus. Now the question comes, how do we differentiate the Staphylococcus saprophyticus and epidermidis? Both of them are coagulase negative. Coagulase or catalase? Huh? Coagulase, right? So, how to differentiate between the two? Now comes novobiocin. Novobiocin sensitivity is very important. So, typically, doctor, if you look at Staphylococcus saprophyticus, it is naturally resistant to novobiocin, whereas Staphylococcus epidermidis and most of the other coagulase negative staphylococci, they are all sensitive. They are all sensitive to the novobiocin. If novobiocin is placed, still the saprophyticus can grow, but if epidermidis cannot grow around it. So that is the buzzword which you are going to remember. So before we say goodbye to the topic of Staphylococcus, doctor, what are the conclusions of our evening clinical meeting? Aureus, epidermidis, saprophyticus. Saprophyticus is only occasional. Coagulase positivity is Aureus. Golden yellow color is Aureus. Mannitol fermenter, only Aureus. And novobiocin resistance is Saprophyticus. Any MCQ asked is based on this important table. So that brings us to the end of the story called Staphylococcus, doctor.